chiropractic sports physician and a certified athletic trainer from Staten Island, New York. He currently practices in a multidisciplinary setting in addition to providing concierge care. His goal is to redefine a patient's healthcare experience by providing high-quality, evidence-based musculoskeletal care, and has gone above and beyond to acquire clinical skills and mentorship from top clinicians on manual therapy and rehabilitation, clinical decision-making, and more. This allowed him to have a systematic strategy useful for managing spinal and extremity complaints. Please welcome Dr. Minlionica.
All right, Randy, let me know when I'm good to go here.
All good to go.
All right. So I just want to thank you for bringing me on. I know there's not been many chiropractors who've had this opportunity. One of the goals when creating this PowerPoint was to not necessarily bring the horror stories of chiropractic to the forefront, but more show you what we can do as healthcare providers and how we integrate ourselves into patient care. So this is my background. I started my career as an athletic training student at Alfred University in Western New York. And from there, we traveled back to New Jersey, where I was a graduate assistant at Kane. So I had all the intentions of having a long career as an athletic trainer. And I really did love that setting. But I became, infatuated with doing more. So I sought out an experience with the New York Jets, where I worked for them for about 2 years as an athletic trainer. And I became really close with the chiropractor who worked with the team. And the scope of practice is larger as a chiropractor, and I was able to broaden my horizons from a patient standpoint. So we know that most people or patients that you work with are not going to be high performing athletes. So being a chiropractor allowed me to provide, high quality care to athletes as well as other populations. So I found myself at Logan University, which is in the Midwest in St. Louis. And then from there, I worked my way to Memphis, where I did a preceptorship working with the athletic community and all of their sports. Currently, I'm a practicing physician at Back and Body Pain Relief here in New Jersey, and I do a lot of side and concierge work out of a boxing gym in Staten Island, where I see a very different population of athlete. So this is Simon Sinek. He wrote a book regarding your why. So this is a huge thing when going into the world of health. No one really goes into it being selfish. We want to make sure that the fulfillment we get from our job brings us forward and always keeps us moving in a positive direction for ourselves and our patient care. So this is my why. My goal is to always be a resource for our patients on their journey of musculoskeletal health, so they can live life without worry and achieve their goals, as well as to redefine a patient's healthcare experience by providing high quality evidence-based musculoskeletal health. Now, I always urge providers to find their why, because practicing any type of medicine is a selfless profession. We really want to make sure that we're doing it for the right reasons, and we get carried through our progression of our careers for the right reasons. Okay. And I find that as a provider, giving yourself as a resource for people who maybe have been through the ringer in the world of healthcare provides me, the gas to continue going. So we're going to talk about how you become a chiropractor and our roles in neuromusculoskeletal care. Chiropractors are obviously mostly thought of as spine practitioners. That's usually where we shine. That's usually not necessarily where the pain is coming from, unless it is. So people can come to a chiropractor for a multitude of reasons. And then once we're done talking, we'll talk about some of the taboo facts or myths regarding chiropractic and how safe it can be. So in order to become a chiropractor, you obviously need to have some type of previous education, usually in the world of physical sciences. However, it's not a requirement. I know people who have gone to chiropractic school who've had business degrees, and they've ended up being phenomenal clinicians. So after that, you apply to chiropractic college. There are about 20 in the United States accredited by the Council of Chiropractic Education. And chiropractic school is about 4 years. And throughout that 4 years, you do have to take 5 board exams. So we're taking them throughout chiropractic school, usually after the first year. The first parts are mostly science-based, where you have your biochemistries, your anatomies, your microbiologies, your pathologies. And then as you get to parts 3 and 4, as well as a physiotherapy test, you get tested more on the skills of being a clinician, whether that's evaluation of the patient or reading imaging such as MRI or X-ray or CT. And then once you pass all that, you can apply for a state license. Now we are licensed in all 52 states, but each license kind of comes with their own scope of practice. So your scope of practice is obviously determined by your state, and we are in most states portal of entry physicians, meaning that you do not need a script to come see us, and we have the ability to write a script for imaging or blood work and so on. If you decide so, you can also try to go on a journey of your postdoctorate diplomate. So there's diplomates in many different types of fields, acupuncture to radiology to neurology. So just because you're a chiropractor doesn't mean you're put in a box of manipulation of the spine. There's nutrition and internal medicine practitioners that are chiropractors. So just because you're a chiropractor doesn't mean you have to adjust, doesn't mean you have to see patients with musculoskeletal complaints. This is really the forefront of everything we should do, is provide good evidence-based care. Now, we want to keep up with the current research, but we all know as clinicians, sometimes the current research is lacking in what the patient wants or what the patient needs. So this is where clinical expertise and the patient's preference comes into play. So we see many patients who don't necessarily want to be manipulated or don't want to do manual therapy. And that's completely fine. It's up to us to find an ethical and evidence-informed course of care for each patient. And this is really where we need to create a good standard, because we know that there are always practitioners out there who may not be doing the most evidence-informed treatment. We want to make sure that we stay within the realm of ethics. So these 3 items here, time, money, and results, is what we want for the patient. We want the patient to get better as quick as possible, spend as least amount of money, and have the best results. We all know that there's outliers on this. There's a pretty big bell curve where people get well real quick, and then there's people who you can't get them better with conservative care that need surgery. So it's up to us to really find out where these patients belong and how to get them as quick as possible. Here's a paper that discussed chiropractors being an initial provider for low back pain, which is one of the more common reasons why a patient would come see a chiropractor. So this study found that 90% of the patients had decreased opioid use going forward. We all know that there is an opioid epidemic out there, and we want to make sure that we're being as open and as open as possible with these patients and what they need and what is going to take them from their current painful state to hopefully leading a healthy life, and that you may not need to take pain medication to be there. Here's another paper regarding lumbar spine surgery, where you go matters. So if you see a chiropractor, you'll probably do a conservative course of care, and you'll probably have good results, whether you're a chiropractor or a physical therapist. But if you go see a medical doctor or an orthopedist, you may be quicker to pull the trigger on a surgery. We know that surgeries aren't, a complete success, and we want to make sure that the patient doesn't necessarily have to suffer through a surgery or postoperative care if they don't have to. My opinion is that we should always exhaust all conservative measures of care before surgery or injection. And another study regarding disc herniations. Most patients, when they see that they have a disc herniation on imaging, that they need surgery or they need an injection. We know now that that is not true and that most disc herniations are in fact asymptomatic. So just because you see a disc herniation on the imaging doesn't mean that it is actually causing you pain. There's a paper out there that discusses disc herniations and the decade of life that you're in, meaning that if you are 50 years old, there's a 50% chance that you have an asymptomatic disc herniation. But if we just take imaging and we look at it from a strict imaging point of view, we may understand that that is where the pain's coming from, but that's not necessarily the case. So most patients will have a disc herniation on imaging, but maybe that's not their pain generator. We know that low back pain is multifactorial. So these are a few papers that really discuss that we need to do better as a community in preventing maybe surgery or injection and exhausting all ways of conservative management. This is really where I feel a chiropractor is useful in classifying the patient. So we all know that we see a patient walk in the door and we know that they're going to be a home run or a miracle case. And then we've all seen the patient who's probably not going to be the miracle case. They have a whole bunch of comorbidities, metabolic disorders, lifestyle issues, yet they have something that, is musculoskeletal in nature. You may not have the best outcome with this type of patient. You really need to classify what is going to get them the best bang for their buck, whether that is someone who's fit for conservative care, or if it's something that does need a more medical surgical approach to care. This is kind of my functional triage of treatment. We know that the research on manual therapy is okay at best. However, when a patient walks into your office, they need some type of relief. I find that if you have some type of tool to get them relief, then their outcomes will be better. So these are kind of my cornerstone pieces that I use. The top is DNS, which is a rehab approach based on developmental kinesiology. And then the Mulligan concept and motion palpation are more manipulative and mobilization techniques. The McKenzie Institute is also a physical therapy based technique that deals with end range loading. I feel that if I could put a patient into any of these categories, that they'll have much better outcomes. And this is kind of what we're looking at from a standpoint of putting the patient in whichever house they belong in, right? So most patients may not need manipulation or mobilization. Sometimes patients need to be stabilized through some good rehab, or sometimes there's some type of metabolic disorder going on and they need to address a functional medicine component, whether that's through diet or lifestyle changes. So these are just what I use. There's others out there that, people will get good results with, but I find that if you have a tool for everything, you'll never have a patient that you can't treat or at least give advice to. These are the three houses that I kind of put patients in, right? Whether that patient needs some type of stability, mobilization, or directional preference. Now, this directional preference bubble here is usually that McKenzie approach to care. We find that if you can correctly put a patient in each of these houses, that your treatment will be much smoother. So not everyone needs mobilization or directional preference therapy or stabilization. You need to find out exactly what they need, and then you roll with that, and then you could kind of fill in the gaps later on there. So I'd say the biggest thing that we try to do in our office here is find out which house that this patient's going to be in. Most of them will need some type of stabilization through some type of lens that we use DNS, but really finding out what the patient needs and what they're going to react the best to. The quicker you get there, the quicker the patient will find their results, as well as diagnosis. So the quicker you find a diagnosis, the quicker the patient will get better. This is a study that we like to talk about when it comes to extremity pain. So just because I'm a chiropractor does not mean that if I adjust the spine, everything will get better. You will find those types of practitioners out there, but that's a different conversation. This study here discusses extremity pain, comes from a spinal source. So I'd say probably about 60, 70% of all chronic pain in the peripheral joint system does refer back from the spine, whether that's a cervical spine, thoracic spine, or lumbar spine. But this is obviously barring any acute trauma. So therefore, if someone comes in with hip pain, if I'm just treating and evaluating the hip, they may not always get better. So we need to find out the actual source of pain and treat the source, because if you just treat where the pain is, you're going to be running around for a while. You want to treat the source and not the location of symptoms. So whenever we come to soft tissues, we know that people come into physical therapists or chiropractors saying that they have, trigger points or muscle tension. And this may not always be the case, as the issue is within the muscle itself. We know that if a joint's not working properly, the body's gonna, compensate and most likely lock that that joint down with some type of muscle tension, trigger points, or tension in the fascia. So we need to find, again, the source of the discomfort or the dysfunction. And then once we get there, we use these soft tissues and dysfunction as an audit process. If you have a good audit process, then your treatment will be much more streamlined, because you'll always know if what you're doing is working. I think that's one of the most important parts in the world of conservative management is to have an audit process, because you need to know if what you're doing is working. This is another study where they injected nerve roots and they told the patients, hey, draw where you feel it. As you can see, there's a lot of overlap here. So this is another, paper that shows that just because we see a disc herniation at a certain level doesn't mean that we are going to have, black and white type of symptoms. So this is why a good evaluation process of function is required. Just because a patient has knee pain doesn't mean that they have, an L3, L4 radiculopathy. We need to find out if that disc herniation is even the cause of your pain. So this is a paper really to just educate people on what you're feeling isn't always black and white. It's not always going to be textbook. And then we could talk about the elephant in the room. The elephant in the room is usually the safety regarding chiropractic. I'm sure we'll talk a little bit more about this when it comes to the Q&A, but large majority of the patients who see a chiropractor do get better and safely. So there are certain conditions that like to get blamed on chiropractors as the reason why, they happen, such as like vertebral artery dissection. And then we do know that there are a plethora of papers out there that discuss the safety of manipulation, and that the screening of these disorders is usually the issue. It's not the manipulation itself. It's the education and the evaluation process. The epidemic of opioid use is just as dangerous, if not more, than what would happen in a treatment room. There's so much more about the myths that occur in the world of chiropractic and conservative care that I'd be happy to take within the question and answer segment. So with that being said, that's the end of the presentation. There's so much more to talk about, but I'd rather talk about it from a question answer platform, so I could really dive down into any specifics that people have.
Awesome. Thanks so much, Dr. Minlionica. And so for anybody who has any questions that would like to be answered, please go ahead and put it in on the Q&A tab for Zoom. But in the meantime, Dr. Minlionica, I'll go ahead and ask a question. So my first question would be, what are those cracks when adjustments are done? Like, what cracks? What's the sound?
So the audible is just a pressure difference in the joint. So whenever you take a joint to end range and you put a thrust into it, sometimes you'll get an audible. That's what we call a cavitation. Now, just because you don't hear a cavitation doesn't mean that there wasn't motion put into a segment. So all an adjustment is putting motion into a hypomobile joint segment. Some people will have the audible, some people won't. But all the audible sound is a pressure difference within the joint. And it's as simple as that.
Thank you so much. And then the next question would be, how do chiropractors adjust patients with different body types? Do you necessarily have to be strong and tall to adjust a person?
You don't. You could have whatever body type or height you'd like. So the best position that you could put yourself in will give you a great biomechanical advantage when it comes to treating a patient. So some of the best chiropractors I know are on the shorter side, where they just lower the table. If you have good speed with your adjustments and are pretty specific with what you feel, and if you feel any restriction, if you're in a good setup, you'll be able to kind of get adequate results. So I've seen, the largest patients be adjusted by the smallest people and still get phenomenal results. So there's always a way around it.
Awesome. And then I think one of the main questions would be, how do you differentiate chiropractors from physical therapists, knowing that, well, from what I've heard, that PTs are also able to manipulate?
Mm-hmm. So manipulation is within the scope of practice of physical therapists. I believe it was Gray Cook who created the SFMA, said that you should walk into a room and not be able to tell if the provider is a chiropractor or a physical therapist. So you should be doing similar things if you're classifying the patient correctly. Someone who needs stability, you're going to work on more active care and stabilization exercises. And if there's restriction in the spine or in a peripheral joint, or even in soft tissues, you're going to want to take care of that. Now, one of the biggest differences in chiropractic is chiropractors are physicians, so you're able to write scripts for imaging as well as labs, and that usually differs from the world of physical therapy. So in most states, physical therapists may or may not be portal of entry, and this allows the chiropractor to kind of have a little bit broader of a scope of practice. But when it comes to actual hands-on treatment, you should be doing similar things. So a chiropractor just uses a adjustment as a tool. Not everybody needs it the same way as a physical therapist could use it. So there really shouldn't be much difference.
Gotcha. Thank you so much. And then what advice would you give to someone who's actually pretty nervous about visiting a chiropractor?
I'd say approach it like you would a friend, right? So you don't necessarily befriend everybody. You want to find somebody that you're comfortable with as a person, as well as a doctor. So if you believe something is going on, you want that doctor to explain to you what's going on, if it's something more sinister or serious, or if it's something that will usually clear up in a normal course of care. I think it's actually good if you have reservations going to see everybody, because it allows you as the patient to have some autonomy and say in what happens to you. So when it comes to being comfortable with manipulation, that's a little bit different. If you're uncomfortable with that, the provider should be able to kind of pivot and give you a different or alternative route of care. But all a chiropractor is a provider that is going to allow you to see better results or to get treated from a conservative standpoint. The word chiropractic or the license of chiropractic is just a vessel for you to treat patients. So I'd say for someone who's uncomfortable seeing a chiropractor, just ask questions and be upfront with what your concerns are about.
Thank you. And a follow-up question is, why did you decide to become a chiropractor?
Yeah, so I think this boils down to what you want in life. So we know that being in the medical field, freedom of time is one of those things that is very scarce, essentially. And as an athletic trainer, there were some things that I didn't necessarily want in my future. So becoming a chiropractor allowed me to have a little bit more freedom of time, freedom of place, right? Because if you want to work as an athletic trainer, or especially what I did, you're kind of limited to where you can work. As a chiropractor, I can work on a larger, a broader patient base. I could live where I want to live, and my hours are a little bit more palatable.
All right, we'll go ahead to this question that was asked. Dr. Minlionica, you mentioned earlier that it is important to find your why when becoming a clinician. Do you have any recommendations of experiences one should collect to determine that? Coming from someone who wants to go into healthcare but is a little bit overwhelmed by the possibilities.
Yeah, go shadow doctors. So find out what you'd like to do and go find somebody that does it and ask if you can be a fly in their wall. So I'd say throughout my world in chiropractic, I probably shadowed over 100 other physicians, because not everybody's the same. So if you're okay, being in an office, in a more medical setting, not necessarily being as hands-on with the patient, you may want to go that route. If you're into rehab, exercise, manual therapy, you may want to go that route. So the biggest thing that allowed me to find out what I wanted was to seek out the people that had things in their lives that I was interested in, and just approach them and say, hey, this is something I'm interested in. Can I be a fly on your wall and just shadow them?
Thank you. And then the next question we have here is, if a patient has medical problems with their bones, such as arthritis, how do you ensure that an adjustment is not worsening it, and teach the patient that it's not harmful for them?
Yeah, that's actually a great question, because everyone has arthritis. Arthritis or osteoarthritis is really just gray hair, right? Everyone's got some of it, but it bothers some people more than others. So all arthritis is usually the body compensating and being a fail-safe, right? So let's lay extra bone down to stabilize it more. So movement is actually great for these patients. Most patients come to me and say, hey, my doctor told me I have arthritis. Okay, so do I. That's okay. All it is gray hair. Once the patient kind of gets scared into thinking that they need to be babied into decreased movement because of arthritis, that's an issue. So us as providers need to empower our patients and say, hey, you have a little bit of arthritis. This is normal when it comes to joint progression, whether it's in the spine or peripheral joint. And we need to find movements and activities that this patient can do pain-free, and really allow them to run with that. So the word arthritis comes up in my office, 100 times a day. And my goal is to always make sure that the patient understands that it's not a death sentence. It's normal. All it is gray hair.
Thank you so much. And then a follow-up question would be, are there any subspecialties in chiropractic?
Yeah. So that's
yeah.
Go ahead, Randy. Go ahead.
Yeah. So like, do you have any specific specialties that you think people should be looking into?
Yeah. So the diplomate in chiropractic is sort of like your residency or fellowship in the world of medicine. So you can become a chiropractor, but then you may want to break out into a more specific role, whether that's internal medicine or functional medicine, or in the world of orthopedic sports. So I'm a certified chiropractic sports physician. So there is a route that allows you to be a little bit more detailed in I guess what type of patient you truly want to see. So I know chiropractors that went through the same schooling as myself, that all they do is consult patients on a functional medicine standpoint. So interpreting and reading labs and how to fix that from a more holistic standpoint. And then I know chiropractors who went through the same schooling, that all they do is do imaging or diagnostic ultrasound, point of care ultrasound, or reading, X-ray, MRI, CT scan. So just because you're a chiropractor doesn't mean that you're stuck in the box of manipulation.
And you mentioned a lot about imaging. Do you necessarily need to be X-rayed whenever you visit a chiropractor?
No. So there's imaging rules that everyone should stay fairly close to. Let's just say for the neck, there's like the Canadian C-spine rules that we want to follow. If there's some type of trauma, you'll probably want to get it imaged, or if a patient has some long-term care, in their past without improvement, you have to figure out if there's anything going on from an imaging standpoint that we're missing, whether there's red flags that are missing. So imaging should be used as a tool, not necessarily the primary driver of care. You always want to make sure that the education off of the imaging is the most important part, such as arthritis. Because when I take an x-ray, I'll probably see some degeneration. And it's my job to tell the patient, what I see and how that will progress in the future. But the short answer is no, not every patient needs imaging. You really just need to find the patients that do, and if it's going to change your course of care.
Thank you. And then we have a question in the chat box actually. How do some of us as pre-meds who often work with physicians who tell their patients to never see a chiro as a rule of thumb do to change the conversation?
Yeah, I think most of the time the current research supports conservative care when it comes to physical therapy or chiropractic. I think as a chiropractor, if a medical doctor or someone in the world of medicine has hesitations, just like a patient would, I think the best thing to do is to have a discussion, an open dialogue on why you believe that we can't co-treat a patient in the right way. We treat patients that are referred from their primary doctors all the way, and they come in with a script that just says low back pain, right? Or just says knee pain. And now it's up to me to treat their patient, with gold standard care and update them on how they're doing. And if I need to, advance anything such as imaging, then have open dialogue with how they could also be involved in the care of that patient. So I think we should really work together more often than point fingers at issues.
All right. And then we have a question that goes, what do you think about neck adjustments and the controversy about that or around that?
Yeah, I knew this one was going to come up. So we know that the vertebral artery dissection is something that is in the news occasionally when it comes to being a chiropractor. We know research-wise that the manipulation itself doesn't usually cause the dissection, that it's usually the task that brought the patient in. So oftentimes there's the typical classification of a hypermobile young female, getting into a skiing accident and comes into the chiropractor with a headache. Now, that patient, you want to make sure that you do your due diligence on making sure that there's no vascular insult, to make sure that you're not causing anything to be sped up. So most of the time when a patient has an issue with the more cervical artery issue, we want to make sure that we're screening that patient properly. So it's traditionally not the adjustment itself that causes it. It's the lack of screening of the disease process itself.
Thank you. And then, are you allowed to adjust pregnant patients?
Yes, you can. So you should adjust anything that's restricted on any type of population. Nobody in this world is better off with restriction, whether that's in the spine or the peripheral joints. When it comes to pregnancy, we actually get phenomenal results with manual care because we know that pregnant women don't necessarily want to take, over-the-counter medications or any type of, over-the-counter medications or prescriptions. So manipulation is a tool that we can use to help them with pain. This really applies to every population. If there's restriction, you can adjust it.
Thank you. And then the next question was, you mentioned you do concierge medicine. Can you speak more on that? How did you start doing that?
So concierge care is essentially house calls, whether, that person is an athlete or an individual that wants you to come to their house. This is something that I've gotten into just being involved in the world of athletics. You find that there's certain populations of people that want you to come to them. And I think this is a good niche that you can have as a conservative healthcare provider, whether that's a physical therapist or a chiropractor. The way I got into it was I've just had patients that said, hey, I don't have time to come to you, but I'd like for you to come to my house. So that's completely within the scope of a chiropractor or a physical therapist. And once somebody gets good results with that, they tell their friends, they tell their teammates, and you kind of run from there.
Yes, definitely word of mouth, right, Dr. Minlionica?
It's usually word of mouth because usually those visits are not reimbursed by insurance, or they're a little bit more detailed with the length of the treatment.
Those other questions, were you always set on being a chiropractor, or did you consider other professions?
Yeah, so as I said prior, I had no intentions of becoming a chiropractor. I was an athletic trainer through and through, and I loved everything about it. You know, when you work in the world of sports, it's an interdisciplinary setting. So I became really close with the chiropractor of the team I worked with. And when it came time to make that next decision about what I was going to do, I really just applied to chiropractor school on a whim, and went and visited the school and had a great experience. And I just kind of jumped in with 2 feet. So I would say probably 4 or 5 years ago, I had zero interest in becoming a chiropractor, yet I have no regrets. And I'm very thankful that I got put on that pathway.
So is it ever late to become a chiropractor or to pursue chiropractic?
No, I went into chiropractic at 25 years old. I was in school with people in their 30s and even 40s. So I think that the later you go into school, it's actually respected, right? Because you're actually finding something that you want to do now. Maybe it's a second career for you to reestablish yourself as a healthcare professional, or to change your career in general. There's no issues with going in later in life.
All right. And now there's a very interesting question that goes, how does someone know that they have a restriction and needs an adjustment versus tightness because of athletics or excessive activity?
Yeah, so the world of research when it comes to joint restriction is not the greatest. However, you have good inter-rater reliability with that, meaning that if I palpate the joints of 20 people, I'll be able to tell where I believe there's restriction, which is a good thing. Now, you need to really evaluate function, right? Is there a bony end feel, or is there a soft end feel, where you can kind of see what is causing the restriction, right? Because if you have a stiff joint, it feels a little bit different than if you have maybe a tight pec because you were doing a lot of chest exercise. So when you're treating a patient, a part of the evaluation is finding out what's causing these restrictions. And then we also need to understand that just because you're working hard doesn't mean you have an injury. So delayed onset muscle soreness is a thing. You don't have torn hamstrings or a spondylolisthesis that's causing your low back pain. Maybe it's just muscle soreness, and it's up to the physician to really figure that out and to give you the best treatment possible.
Thank you. And then we also have another interesting question, which sports teams have you worked with as a chiropractor for in the past? If you could say.
I had not worked with any sports teams as a chiropractor. So when I was working with sports teams as an athletic trainer, I worked with the New York Jets, as well as Kane University, which is a Division III school in New Jersey. As a chiropractor, my career has mostly been in private practice and concierge care.
And it says, can you comment on how sports medicine differs from a chiropractor's practice? Do you work with any sports medicine specialists?
Yeah, so theoretically, I'm also a sports medicine specialist when it comes to my degree in athletic training, as well as being chiropractic sports physician. The biggest difference here is acute care. So when someone tears the ACL on the field, you have a very different evaluation and triage process versus if someone comes into your office with an ACL, or if someone gets spear tackled on the middle of the field, and I have to evaluate if there's a medical emergency present or not, versus someone who comes into me with head and neck pain. So the biggest difference when you're involved with sports, or if you're actually covering the sideline, is the acute care and how to triage that properly.
All right. And then our last question is, could chiropractoring be a stepping stone in pain management? Maybe providers trying to stop the opioid crisis should look at the benefits of chiro?
Yes. So pain management or pain management doctors is, I co-treat with them all the time, because let's take like a lumbar radiculopathy or a radiculitis where there's severe nerve root impingement. You have to fight chemical with chemical. So if there's so much inflammation in that nerve root, sometimes we do need to inject something in there. If they're not responding to my care, what's the next step for them? Maybe it is pain management. So I think if the patient has failed a course of conservative treatment, there's no reason why you can't refer them to a pain management doctor to get their take on it. And I've worked with pain management doctors that say, hey, you're not there yet. And then the others that say, we're going to schedule an injection. You're going to continue with care, and we'll see you in 6 weeks. If it's not better, then we can pull the trigger on injection. Where I stand is we just don't want injection to be the first line of defense. We want to make sure that the patient could do everything that they can without an injectable.
So would you say we're leading more towards an integrative approach with other healthcare professionals?
That's how it should be. I mean, the world of pain management doesn't necessarily mean you're injecting people all day. Being a doctor means you still have to do the right thing by the patient. And if that patient isn't in your wheelhouse yet, let them go to conservative care, let them go to the PT or the chiropractor, and see them when they need you. I think the omission of treatment is just as important as the treatment itself.
Thank you so much, Dr. Minlionica, for your time and for your presentation. I hope everyone was able to get a bigger or broader perspective on chiropractic and learned a lot. And we'll see you in our next session on University of Pennsylvania School of Nursing program.